Ladies and gentlemen, we have the next 45 minutes for an ECG workshop. May I, without any further delay, invite Dr. Ulhas Pandurangi to please enlighten us with the ECG workshop. Dr. Pandurangi, please.
I believe this session is going to be interactive and probably it is a fun activity before we wind up today's program. So the pattern is I'm going to be showing an ECG, and there are some choices which are part of the answer. I believe the ECG is seen clearly. If this ECG is shown and in addition to the ECG, if the clinical details are given in the form of the age, 28 years old, male, and the family history of coronary artery disease being father has had a coronary event at the age of 80 and this patient has a persistent chest discomfort for 3 days, the question is, what is the right option to be chosen? If anybody, that's the right choice here. It is reassure because they are part of reassurance for several things. Chest discomfort is usually paroxysmal, lasting for a few minutes or so, and you are looking at really a low probabilistic situation for a coronary artery disease, 28-year-old, quite young. Chest discomfort which is persistent for 3 days is unlikely to be coronary artery disease unless he is in the hospital and then is being taken care, but if he is outside the hospital, he is unlikely that he would be surviving. And the family history, the emphasis it is of importance only when there occurs a premature coronary artery disease in in the family. So that history itself is a situation which is telling you that you are dealing with a patient with a very, very low probability of coronary artery disease. And now coming back to the ECG per se. Well, there is a tendency for an ST segment to be elevated, but we are all taught by the ECG criteria people that it is not just the elevation, it has to be significantly more in the anterior precordial leads, and it should not be less than 2 millimeter and consistently in at least 2 contiguous leads. So even though there is a tendency that there is an ST segment elevation in V2, V3, they are not more than 2 millimeters. And looking at lead, inferior leads, again there is a kind of a tendency for an ST segment getting elevated. Again, look at the pattern, it's a concavity upwards. Again, there in the inferior leads, well, 1.5 is good enough, but it is not even 1.5. What is important here is look at some of the other patterns. Sinus bradycardia associated with a tendency for the ST segment to get elevated with a notch at the J point. These are the notches, lateral precordial leads seen in inferior leads. Look at this, there's a kind of a notch, ST segment getting elevated. If you look at the TP as the baseline, you have the ST segment elevation not really more than 1 millimeter. So this ECG is read more often as a representative of a coronary artery disease, especially there's a history of chest pain. So I believe this slide is telling you the importance of taking the clinical history very well and what actually you mean by the family history and the duration of the chest pain in case, if you're looking at chest pain is a clue for a coronary artery disease. So and hence this ECG should reassure.
This would mean something else also. This is early repolarization, I agree. It looks like that.
Yeah.
But then if your changes are there in inferior leads also, that tells you that these are the patients who can have bad outcome later on.
Right.
I mean, this is what.
Right. There are some early repolarization changes which are no more considered benign and they can be considered as malignant. The data is less. And only there are few series where they have made this point out very seriously in a person whom you think has had a syncopal episode or a resuscitated arrest, or the person has a family history where the sudden death etiology was unknown. As long as these three entities are not there, I think still it is all right to continue read these ECG changes as benign early repolarization changes rather than highlighting a very, very low probability of a sudden cardiac arrest in this patient. Point well taken. Have this in mind. Maybe over a period of time, in addition to early repolarization changes, we may be asked to do a couple of more things which would aid in risk stratification. So, chapter is not closed. Eyes to be remained opened. We are looking at little more studies to go to the extent of alerting our patient that you have a risk for sudden cardiac arrest. It's a big statement to be made which can cause such social and psychological distress. This is a lady comes to you asking for fitness because she wants to join airlines. 32 years, female, high endurance athlete. What are you asking her to undergo in case if you are unwilling to give her fitness? I believe this ECG should carry a recommendation from your side to her employer that she probably is going to be the fittest lady in that organization, because this ECG is a manifestation of really high endurance athlete training in the form of a sinus bradycardia with a prolonged PR, which are really seen very, very often in patients who are high endurance athletes because they have high vagal tone. The apparent pause indeed is a concern, but when we look at the reason for this pause, you make this P wave as a culprit. This came earlier than expected. So this is a premature atrial contraction, did not conduct because her node is vagally very well toned. So this ECG is not a cause for concern. I think this ECG should make you to be very appreciative of her efforts and give her a certificate of appreciation and a letter to the employer that she be taken up very quickly before anybody picks her up. There are two ECGs for your analysis because they are shown because the decision is going to be very significant. The year 2013 showed an ECG, right bundle branch block, with a QRS width of about 120. We call it as complete right bundle branch block, with an AV conduction being normal, PR is okay, and then the QRS axis is okay. He was asymptomatic in the year 2013. This 60-year-old gentleman, when he attains 61st year, he undergoes another health checkup just to keep himself fit and be knowing that everything is all right. So this is again an asymptomatic status wherein you see some changes in the ECG. I will bring your attention to the widening of the QRS, but still resembling right bundle branch block, with a PR little longer than this, attaining almost like 200 milliseconds, with a conspicuous change in the axis towards the left side. So with this history, are you going to ask him to undergo angiogram? No, you don't. You ask him Holter because there may be blocks you under. So you assure him only when it is normal, or you start straight away asking him now to think about pacemaker because you have got serial ECGs with you. No, none of these things will help. Electrophysiology studies specifically looking at the HV interval may help, so you recommend EP study. I believe this is not an uncommon situation. It is just that we don't keep our patients' ECGs in a serial fashion. For example, this case tells you that if you have an opportunity to keep your patient's record, the ECGs at least are going to be of so much importance when it comes to evaluation of arrhythmia, blocks, coronary artery disease. And if you ask me everything, at that point in time, if you have taken an ECG, you would like to have what was the ECG taken in the past. So, I would like to tell you people that here you should counsel this patient, strongly for the pacemaker. Number one, if you look at the options given, an angiogram is going to tell you there is an associated coronary artery disease or not, but coronary artery disease or ischemic heart disease is not a cause for gradual progression of conduction disease. You may do an angiogram for other reasons when you are looking for a pacemaker implantation, but here the angiogram is not helping you. A Holter in one day, 24 hours, and sometimes an extended Holter for 48 hours, if that is going to be normal, you are back to the square one, because during those 48 hours he did well. So did not mean the next 24 hours he's not going to have a block. EP study has its limitations. A normal EP study is not an indication that he wouldn't have this problem, say 6 months later, because you have this progressive conduction disease documented so very clearly. So an EP study, when you are doing it, when you are following the recommendations, please read the recommendation there. It is at that time what was the ECG. So that EP study recommendation was not on the basis of how the patient had his conduction problem in the past few years. So EP study probably would not guide you. And why you should be really serious about counseling regarding the need for the pacemaker in this patient. In 1 year period, you have a documentation that the fascicles are getting more diseased. Right bundle branch block, which was sleeker 1 year before, has become wider, and most importantly, it started becoming non-specific. In addition to the right bundle getting more diseased, you have another fascicle is also showing signs of degeneration in the form of a leftward axis deviation, which is a manifestation of left anterior fascicular problem. So you already have almost a trifascicular block, which, even though is asymptomatic, it is progressive. So I believe this ECG or this slide is representative of a fact that it's better to always correlate with the past ECGs, and sometimes the guidelines you got to read between the lines when you are reading the guidelines. EP study could have been all right if he has come specifically for the evaluation of the need for the pacemaker in asymptomatic status. But in this case, the EP study situation is different. You'll have to put me into trouble. The question was, the patient has come with 2014 ECG to you, and there are no ECGs to compare, and he is asymptomatic. What do you do? In all probability, let's be blinded. What all I had told. Let's not confuse this. Now, this is the ECG. I would tell this patient, go home. I would like him to come back soon for a few tests, a treadmill test, a Holter test. And I asked him, why did he come to me? Is it because of the clearance of his job, fitness for a certificate? And I would look at his day-to-day activities, whether he is going to have a syncopal episode which is going to be causing so much of a social damage. I think all these things put together, I might ask him. But if he is a 60-year-old man, a retired employee, had been doing very well, I would not do anything more. Only when if he asks, why doctor, last time you did not ask for the Holter, this time, then only I will go and start telling him, I would like to underplay the importance of this trifascicular block in a 60-year-old healthy adult patient. But well, I know that I may be wrong. But that chance of me becoming wrong, according to the literature, is so very low that legally I will be pardoned if this gentleman gets syncopal episode the next day. For example, this patient, indeed, before we actually consult further, he has had this absolute trifascicular block, and he also had symptoms because of the CHB. So this ECG is asking you a few questions. Anticoagulation is recommended just because you saw this ECG. You're also looking at the beta blockers and the calcium channel blocker. You're also looking at RFA. And there is an option that you should actually consider all of them. I believe all of them is a correct answer because it includes few elements. One is anticoagulation. Atrial flutter is prognostically as much serious as an atrial fibrillation. And anticoagulation is recommended. If you follow all those risk factors we just now discussed, if this gentleman fits into that category, anticoagulation should be seriously considered. This is a typical atrial flutter. If you cut off the heads of the R waves, you are left with sawtooth appearance. This is classical sawtooth appearance, which is classical again of a typical counterclockwise flutter, which is very, very effectively cured by radiofrequency ablation. And with such kind of a rate, I think it is appropriate till such time you do some interventions, consider some rate limiting drugs in the form of a beta blockers or a calcium channel blocker. So this is a classical case of an atrial flutter, typical fast rate, risk assessment, anticoagulation. So the answer is all of the above. This is another Holter strip here, which is belonging to 60 years old male, but now syncopal episodes. I read this Holter for you people. There is a tachycardia episode with a rate of about 160 beats per minute, almost regular narrow QRS, and then you have significant ventricular asystole amounting to about 6 seconds. And you have another strip of the same patient taken at a different time where there are narrow QRS premature beats, and looking closely, it looks like premature atrial contractions. So you're dealing with a tachybrady patient who has syncopal episode. What are we doing here? Just do a pacemaker or an anticoagulation with the pacemaker and a corderon or a radiofrequency ablation. Or, it is good to do as much as possible because you care so much for your patients. Why not do everything, including an angiogram and corderon? Well, which is inappropriate. What I think the best thing to do in this patient is to look at a permanent pacemaker implantation anyway, because that is not going to, nothing less than a permanent pacemaker is going to obviate the need for prevention of syncope because of the pause. PPI is definite. Now you have tachycardia and a bradycardia, and this bradycardia was definitely because of a sinus dysfunction. So we already now know this is a tachybrady syndrome because of a sick sinus disease, where the instance of atrial fibrillation episodes, even though here it doesn't look like, are so very high that there is, during the tachy phase, there is atrial fibrillation, so he requires an anticoagulation. Now, PPI and anticoagulation, when they are thought of, then there is a competition whether to consider an RFA or a corderon. The corderon is a good drug with respect to atrial fibrillation, but it is not a guarantee that it is going to be all the time terminating this kind of a tachycardia. So the patient, when he develops a syncope, we should not be thinking that this patient has had only this brady episode. A 60-year-old male in a standing position, if he suddenly goes into such kind of a rapid tachycardia, time and again we have seen that these may develop syncopal episodes. So, corderon, if you are looking at just a control of an arrhythmia, is all right. But if you are looking at preventing such episodes and preventing syncopal episodes, is not a right thing to do. So corderon is not a great choice. It may control the ventricular rate during this time, all right, but it may even prevent this, but it is not a guarantee. But now you are dealing with a patient who has syncopal episode. Don't take a chance. So he has to have a controlled ventricular rate all the time, and that you can achieve of a radiofrequency ablation, either targeting atrial arrhythmia, but the best thing is to do the AV node ablation. So he is now free of medications. You take care of his anticoagulation. So patient will have only anticoagulation. And again, a coronary angiogram probably is like doing over than that is required. I believe this is one of the easy ECGs, which is showing you a very fast ventricular rate in the form of fast, broad and irregular QRS complexes. So the diagnosis, I'm sure everybody is in agreement that it is an atrial fibrillation in the presence of an accessory pathway, which is also called pre-excited atrial fibrillation. The point here is not the diagnosis, which is so obvious. The question is, what is the best therapy? DC version, amiodarone, DC version, digoxin, DC version, beta blocker or a calcium channel blocker, DC version and RFA. So it is picked up, the right answer was picked up correctly by the front rower. It is DC version and a radiofrequency ablation because this is a life-threatening situation. The diagnosis is an atrial fibrillation in the presence of an accessory pathway. This you cannot just expect this patient to be asymptomatic. You cannot even just be expecting that he has got less symptoms. Nothing less than a syncope or a cardiac arrest probably must have taken place. So if the patient is lucky enough to reach with this, before he could even say anything, if you got this ECG, he needs to have a DC version. So DC version seems to be a common element among all these four options. When this is the situation in this accessory pathway, you are not going to rely upon any one of the medications, because of their varying pharmacokinetics and the varying autonomic influences may not be very effective all the time. So on the drugs, the patient can still be at the risk of atrial fibrillation with a fast ventricular rate. So you're not going to take any chances, and hence you should strongly recommend this patient, after you revive him with a DC shock, to send him for the lab at the earliest to prevent such episodes, so that he can get the radiofrequency ablation performed. In fact, an accessory pathway without even the documentation of an atrial fibrillation, if there is a history of a syncopal episode, class 1 indication for radiofrequency ablation comes in. We have another right bundle branch block kind of a thing. What is the diagnosis? Right bundle branch block, WPW syndrome, Brugada, or an acute anterior wall MI. I think this is right bundle branch block. It is not WPW syndrome because the PR interval is short. So PR interval is not short. And then the initial complexes of the QRS are not slurred. In fact, they are quite sleek or sharp uptake or sharp downstrokes. Delta is absent, PR is within normal limits, so rules out WPW. Brugada syndrome, here you have a ST segment coving which does not come and touch the baseline. What it is seen here. Here, the J point is not elevated. In Brugada, the J point is elevated with a coving pattern. So there are chances that you may get confused with the Brugada versus a right bundle branch block pattern. Acute anterior wall MI sometimes is also entertained with this ECG. The T wave inversions, which are physiological and secondary to the right bundle branch block. A little bit of an elevation of an ST segment is an integral component of a typical right bundle branch block. There's another right bundle branch block pattern here. You have a short PR and a delta wave, so there's no confusion. So these two ECGs, many a times people have confused with Brugada and an anterior wall MI. That is why this has been shown. And sometimes the pre-excitation is missed out because it was considered to be a right bundle branch block because the PR interval was not looked at clearly, or the delta was not looked at keenly. So this is another ECG which is misread many often, which is telling you that there is a loss of the R waves in the anterior precordial leads, and there is this, almost like RS in, QS in inferior leads, especially in lead 3 and AVF. Many a times people have treated this ECG as a coronary artery disease, representing either as an anterior wall MI or an inferior wall MI, and some people have read it wrongly because there's a wider QRS in the lateral precordial leads because it's a left bundle branch block. But what is important is there is hardly any PR segment. Look at this V3, and then the takeoff is not sharp. And so these are short PR, broad QRS, is a typical of a right free wall accessory pathway. More often than not, they may remain asymptomatic. For some chest discomfort, if the history of a palpitation is not there, and if this ECG is looked at casually, you may think this is a patient of coronary artery disease. And several instances of these patients coming for an angiogram to the institute is known. We have a left bundle branch block here. Now there are questions. It is left bundle branch block, or if it is a left bundle branch block and if there is a typical angina and there is no previous ECG to compare, and this is good enough for you to take him for a thrombolysis because you consider LBBB has masked the typical signs of myocardial infarction, and you are erring to the side of MI because you thought giving thrombolysis is probably more beneficial than the expected complications in the form of bleeding, stroke, etc. So you dared to take this patient for thrombolysis because you believed in his history, which told you that he has typical angina. Well, this is the ECG, but your patient now is different. He has got congestive heart failure. May you consider him for implantation of cardiac resynchronous therapy? So what could be the answer? I believe the answer is all of the above, because it's typical LBBB, and it is wise to consider thrombolysis if there's a typical angina. And we heard earlier, congestive heart failure patients who is resistant to your treatment, class 2 and above symptoms, optimal management, and this is kind of a sinus rhythm with such wide LBBB beyond 150 milliseconds. According to the guidelines, this is a class 1A indication for CRT. So now we have a question here based on this ECG, WPW syndrome, non-STEMI, apical hypertrophic cardiomyopathy, and none of the above. Can anybody? Let's go by one after the other options. Well, if you look casually, there are PQRS complexes which are connected closely with obliterating the normal PR interval. Look at this. This is the PR interval which is short. If you will see here, PR interval is short, PR interval is short. So it suddenly raises the antenna regarding the pre-excitation because of accessory pathway. However, that relationship no more exists beyond these 3-4 complexes because the P tend to be not giving rise to the QRS. For example, in this particular, the P is probably hidden here, and the P probably is getting to merge into this QRS here. So we are dealing with the dissociation of the atrium and the ventricle, which is not seen in WPW syndrome. So this is not WPW syndrome. Non-STEMI, well, non-STEMI could have been okay if there was a history, could have been there, but it is less often that there is T-wave inversion alone, and T-wave inversion associated with this kind of an isorhythmic AV dissociation and having such QT prolongation. Look at this QT prolongation. It is more than 75% of the RR interval. And we know that the QT interval prolongation, which is a risk factor for ventricular arrhythmia, can have episodes of atrioventricular dissociation, appearing sometimes short PR. So this is not non-STEMI. This is some long QT types. And this is also not apical hypertrophic cardiomyopathy because the T-wave inversions, no doubt, can be inverted even in the anterior precordial leads, but in typical apical hypertrophic cardiomyopathy, you tend to have really remarkable T-wave inversion in the lateral precordial leads and unmistakably in lead 1 and AVL, which are absent here. So this is not apical hypertrophic cardiomyopathy. Ramakrishnan, should I stop? So that was important to recognize that long QT because very quickly you look at it whether there are any reversible causes of that long QT, because this patient, before we could evaluate further, has had this episode. Indeed, this patient presented to the emergency because of the syncopal episodes. This probably is my last ECG. Let's look at this 60 years old male who has significant risk factors for coronary artery disease. Because not only he is that age, which itself is a risk factor according to the speakers earlier. Now that in addition to the age, he has another risk factor, heavy smoker, and importantly, he comes to you with chest pain and breathlessness for 2 days. Significant ST segment changes. So what is the option? Notice there is a global, if you can permit me to say that, is there. Global ST segment elevation is there. But we look carefully, AVR, because this is an exceptional lead, we don't really look at that with respect to the definition of a global ECG changes. When we say global, unfortunately, we exclude AVR. So let's exclude AVR and let's look at global phenomenon in the form of an ST segment elevation everywhere. Maybe only isolatedly in lead 3 it is a little less, but except in lead 3 there is a global ST segment elevation. And you have a real high risk coronary artery disease patient. So despite all these scary things on the ECG as well as the clinical profile, I still believe you can go slow here because there are certain things to notice. A global ST segment elevation is a rarity. Usually, when there are many leads which are showing ST segment elevation, one or two leads will show significant ST segment depression. It is impossible to have more than 5 or 6 leads to have a ST segment elevation and an ST segment depression not being in some other leads. And that is what exactly it is happening. There is no ST segment depression. Global ST segment elevation in the absence of an ST depression in anywhere is unlikely. The situation is an acute coronary syndrome. Few more things. If you have an ST segment elevation in some leads where it is concavity upwards, is again a sign that it may not be acute myocardial infarction. And if you have some ST segment depression in AVR, again it is not an indicator of left main disease. As long as you have a concavity upward ST segment changes, no ST segment depression, and typically if this is associated with some notching, which is early repolarization sign, all is possible in a condition called acute pericarditis where the manifestations can be similar. So this is an acute pericarditis, very classical. Over a period of 3 days you will see dynamic changes in this. So ladies and gentlemen, there are ST segment elevations of this kind, and if you think you can put the smiley onto that kind of an ST segment, and if you notice some kind of early repolarization changes, you can be rest assured you are dealing with not really a serious case in the form of an acute coronary syndrome. Thank you.
Ladies and gentlemen, that was the last session of day 2. We are in fact facing a strange predicament. We have finished 30 minutes ahead of time, though the scheduled time was 6 p.m. in the evening. You can time your watches. We are at 5:30. We'd like to thank all our faculty members, the chairpersons, and the wonderful audience for being kind enough in helping us have the sessions well ahead of time.